Today, as you can see from the topic, we'll be delving into how do we manage patients who are within the cohort of respiratory diseases. And our presenter today is none other than Robert Kemboi, who has been in the clinical space for some time now. And I believe he's going to provide us with vast knowledge in terms of what he's managed to gather in terms of these years of experiences, in terms of what works, what has he seen that are some of the challenges that we are facing. And with that, I believe we are going to have a nice discussion centered around the respiratory diseases. So without further ado, welcome Mr. Kemboi to take us through this session.
Good afternoon, all, and thank you for creating time to attend for today's webinar series, nutrition webinar series. And today we are going to see a medical nutrition therapy in a respiratory disease. We are going to start seeing about what are the respiratory diseases. And we are saying that the respiratory disease is any disease and disorder of the airways and the lungs that affect respiration. This could be infection, post-infection complication, chronic diseases such as asthma or chronic obstructive pulmonary diseases, diseases that indirectly decrease pulmonary functions. That is neurological diseases such as ALS, acute respiratory disease syndrome, developmental diseases such as cerebral palsy. This is a study that was done by Intertupers Lung DIS21, as you see, about chronic respiratory disease in adult outpatient in 3 African countries. And it was a cross-sectional study. And as per the study, it indicated that asthma contributes to 36%, which is at a larger percentage, then chronic bronchitis, 25%, COPD, 8%, that's chronic obstructive pulmonary disease, 8%, bronchiectasis, 5%, and post-TB lung disease, 4%. We have risk factors to respiratory diseases, and I've illustrated, as illustrated by Christensen et al. 2002. That next year's exposure, that's the primary smoking in the next year's exposure. The Christensen et al. Had 4 factors, that is next year's exposure, individual and social factors, general external environment, early life risk factors. Those are the pillars that we're looking into. And under next year's exposure, we're looking at the primary smoking exposure, indoor air pollutants, secondhand smoke, occupational exposures, ambient pollutants. They were checking on all those aspects and relating also to individual and social factors like socioeconomic disadvantage, access to healthcare, racial and ethical disparities, as well as diet. In the general external environment, we are looking on neighborhood built environment, food access, racial segregation, climate. In climate, we're checking on the temperatures and humidity. A built-up environment, we are checking on housing, structure, quality, and appliances. While on the Other parameter, early life risk factors, premature birth, asthma, and early respiratory infection, maternal and prenatal exposures, childhood exposures, growth trajectories, and also late life risk factors. Example is age and other comorbidities that one person has. Then the relationship between poor nutrition and lung disease. This is by Sain et al. It's the latest research that was done. And poor nutrition will lead to poor alveoli health. That's the growth of alveoli. Also, the growth is also depressed, and also the defense is also depressed. Following that, that is an acute phase, and also in an chronic inflammatory and phase, there is increased cytokines, and these are cytokines. These are substances that were produced due to inflammation, and also a person had defective absorption, decrease in appetite, and loss of weight. This is the cycle of interrelated factors between nutrition and lung disease. The consequences of malnutrition in COPD. This is by FRG et al. That is 2020, and they were saying that the consequences of malnutrition in COPD will lead to reduced muscle strength, reduced respiratory function, muscle function, longer hospital stays, increased health costs, increased healthcare costs, increased mortality. They were actually relating the cost of the cost and also the importance of the disadvantages of malnutrition, which is associated with respiratory diseases. And they were so evident that there is actually reduced muscle strength. There's also reduced respiratory muscle function in terms of breathing in, breathing out, gaseous exchange, metabolism. Also, longer hospital stays. This is because it takes quite some time for one to heal, and therefore you spend more time in the hospital. Also, and that is accompanied by the cost. We have also increased healthcare costs and also mortality. So the medical nutrition therapy in respiratory disease. We have the goals. It was actually a preamble. What we were doing was a preamble relating various scholars and various findings on these respiratory diseases. The goal of nutrition therapy during pulmonary disease is actually to prevent or minimize the loss of respiratory muscle, minimize pulmonary function, and to provide maintenance or repletion therapy. Maybe before I continue, am I audible enough?
Yes, you are.
Okay, thank you. Then we continue. The backbone of nutrition before intervention, the entry point is nutrition assessment. Assessment is very, very, very important in evaluating the nutrition status of the patient. And the assessment will start with anthropometric measurement, that is weight and height. And the BMI, that is the body mass index, is an indication where we do a calculation by comparing the weight and the height of a particular patient and particular individual patient. And according to the BMI scale, any person scoring 18 is deemed to be underweight, 18.25 is healthy. Then any person scoring 25% is overweight. And as per the recent studies, the recent history of a patient who experiences or who testifies that has weight loss or weight gain, and we are saying 10% of the body weight. If you are losing 10% of your body weight or more in more than 6 months, is an indicative of malnutrition. However, either whether it's intentional or non-intentional weight loss in more than 6 months, you are indication of getting towards malnutrition. So as we had started that in the assessment, we are starting from anthropometric measurements, that is doing a comparison of weight and height. We're also checking on biochemical data. This is by assessing the laboratory works. And we are checking on BMP and electrolyte lab works, the respiratory quotient, and blood carbon 2 oxide stroke blood oxygen levels. A high respiratory quotient is an indication of overfeeding. And when you overfeed the patient, there is an increase in pulmonary stress. And therefore, we are checking on the intake of oxygen versus the carbon dioxide that is being produced, and make a comparison whether we are overfeeding the patient or underfeeding the patient, which will affect the strength of the pulmonary. And therefore, it's very, very important for one to do a biochemical assessment. I'm not saying singling out this carbon dioxide versus oxygen intake, but we have other parameters that are very, very important. Clinical assessment, and through that we are doing a nutrition focused physical examination. We are checking on the fat loss, the muscle loss, and the evidence of all those fat mass, muscle mass, nutrition focused physical assessment. Then we tally them all and make a judgment, an informed judgment. We are checking then when one loses weight 10% in a period more than 6 months, there is possible weight loss. You may find that when you assess this patient physically, find that there is sagging, there is loss of muscles, there is a bone is evident, and therefore it's very, very important to carry out an assessment on clinical assessment. We have also diet history, that is examining the patient past feeding plan, whether the patient was taking enough of the calories in terms of both macro and micro minerals, because a healthy person should have a history of taking a balanced diet. And when we talk about the balanced diet, we're thinking about the intake of both micro and macro nutrients, which will bring out give us an informed decision about your dietary practices. Now calories, and we talk about calories is just the amount of energy that is required by your body. But in the physical space, when you talk about caloric, we are talking about the energy that is required to raise 1 gram of water by 1 degree Celsius. But now here is the amount of energy that a human being, or rather we as an individual, requires. A pulmonary patient has an increased caloric needs. Overfeeding increases strain in pulmonary system and can lead to decreased functioning. Decreased functioning will actually go hand in hand with decreased amount of oxygen that one is taking, and therefore comparing to the requirements of oxygen of an individual. So approximately an individual has to take up to 30 kilocalories as a healthy person, 30 kilocalories per kg body weight in each and every day. And the daily energy requirement in order to elicit weight gain are likely to be considered a higher, up to 45 kilocalories per kg body weight per day. The extra 15 that we're taking up from 30 kilocalories per kg body weight is to gather for weight gain, which is a very, very important parameter, which will also affect the immune system. It will affect the daily activities of a person positively. If a patient is experiencing edema, use a patient's dry weight. When we talk about edema, this is a patient's inability to remove all waters from the body. And therefore, when you take the weight of the patient who is edematous, it will not give us the actual weight, but rather we use the dry weight. We assess the patient and ask the patient about the previous weight before edema presents. If the patient is obese, adjust the body weight to avoid overfeeding the patient. And adjusting the weight, you take the weight and you place the patient on the category in the BMI that is normal, depending on your assessment. And here is a table, or actually an illustration about requirements by the patient's clinical status. Clinical status of the patient, daily caloric requirements. So for a patient who is sedated with mechanically ventilated, requirement goes between 20 to 25 kilocalories. Unsedated patient, mechanically ventilated, 22 to 24 kilocalories per kg body weight per day. And the patient who is on spontaneous breathing, critically ill, but breathing spontaneously, 24 to 26 kilocalories. Spontaneous breathing, the ward, actually in maintenance, that is 24 to 26 kilocalories. And spontaneously breathing ward patient with a repletion, that is 25 to 30 kilocalories. The protein part of it, the protein needs are slightly increased in patients with pulmonary diseases, which is aimed to restore the lung and muscle strength. Remember, we are saying we are not overfeeding these patients so that we do not stress the pulmonary function, but we are giving enough to maintain or to restore the lung and muscle strength. Also to promote immune function. And this is the general guidelines is 1.2 to 1.5 grams of proteins per kg body weight, or other amino acids for kg body weight per day. While an average individual requires 0.8 to 1.0 grams per kg body weight of the amino acid. Whereas the fat requirement, it's recommended that high fat, low carbs diet when trying to wean breathing assistance during the periods of acute respiratory diseases. I recommend the following ratios: proteins, 15 to 20% of the total calories, fat 30 to 35% of the total caloric, then the energy requirements, the carbohydrates, energy giving, 40 to 45 of the total kilocalories. When you tally all protein from protein portion, fat portion, and the carbohydrate portion, you will be able to get 100%. And we are saying excess carbohydrates increases carbon dioxide production. And therefore, we are saying that we need high fat. Not necessarily that it's very high, but high fat, so that we can control the carbon dioxide production and increase the patient reliance on the breathing assistance. And here comes with food pyramid table for the dietary management of COPD. I know everyone is conversant about the food pyramid table, but this is one that is developed by Rand Ali et al. In the year of 2020. That in the bottom of the pyramid, every day, minerals 1.5, mineral water, that's 1.5 to 2 liters, that an individual has to take. This is actually for hydration purposes, and also there is some minerals that an individual may actually have lost, that is mineral depletion. And we are saying that the vegetables, that's the second part of the section, vegetables and fruits. And we are saying that a portion one needs to take 5 portions of food. That is for a patient with COPD. Then 3 to 4 portions of extra the portions of the liquid, the oil, and the whole grain should also be 1 portion, 2 portions of low-fat milk, light yogurt, or red wine in a day. Then fish oil that is rich in omega-3, omega-6 fatty acids, 4 portions per week, and 2 portions per week for animal protein. We also have red meat that is 1 portion per week for this particular patient that has a COPD. This is as per the Radali et al. 2020. Fluids therapy. The fluid prescription should include the daily maintenance requirements of water and electrolyte replacement of any losses. Fluid requirements of 20 to 35 ml per kg body weight is sufficient to maintain adequate hydration state of the patient. Whereas when you do a fluid overload, is calculated as a percentage of fluid overload, that's FO, using the following formula. The fluid overload is total daily fluid in the bracket fluid intake in liters minus total output in liters. Then you divide by baseline body weight. Then you multiply by 100. That is actually a formula that we calculate the percentage of fluid overload. And we need to pay attention on the concentration of sodium that a particular patient is given. Sodium restriction, that is less than 1 millimole per kg body weight per day, should be considered in the first days after the start of the nutrition therapy in order to avoid fluids overload. Nutrition therapy in unintubated patients with acute respiratory failure. This is actually a flowchart on that were developed by SP et al. 2021. That acute respiratory failure in an uninvasive ventilation or high flow nasal cannula will lead to inability to tolerate oral intake or inability to obtain less than 50% of the caloric goal by oral diet after 24 hours. You need to assess your patient, whether the patient is getting enough above 50%, that is a half of what the patient is supposed to take in 24 hours. Then you check on that. Then that one will inform you either whether it's due for severity of illness or the patient is at is due to altered mental status, due to impaired swallowing, contraindication to oral or enteral feeding. If the patient is not taking the calories, a half of the calories, that is suboptimal intake. Now you will have to know critically that whether the patient is due to severity of illness, or is it due to altered mental status, or is it due to impaired swallowing, or is it either due to contraindication to oral or enteral feeding? And when you have made a critical judgment, you may now come an intervention and assess and say now that this is indicator of failure of an invasive ventilation or high flow nasal cannula. Reassess the patient for need of endotracheal intubation. Then you may consider also enteral nutrition via tube feeding. This is an either through an nasojejunal or NGT or other enteral forms of feeding the patient. Then you decide if there is a mental, there is altered mental status. You think on the options on how you can feed the patient. If the patient has impaired swallowing, then you repeat modified barium swallowing study. Then if there is contraindication in oral or enteral feeding, you consider parenteral nutrition. Either partial or total, or either select parenteral. Here is actually a study that was done by Sarah Krishna, Cozy Silva, Francian, and all those that are indicated here about immunomodulatory roles of nutrients. How can a pulmonary dysfunction improve? And in this figure, we are saying about immunomodulatory properties of nutrients in lungs are able to ameliorate and develop the severity of pulmonary disease, since they can act as several immune cells and modulants. Module immune response in inflammatory process. I remember we talked about cytokines, and the immune modulants are a product of inflammatory processes that the patient is getting. And in this context, minerals, flavonoids, vitamins, and fatty acids reduces the expression of inflammatory modulators, such as cytokines and chemokines, as well as have antioxidant effect, which decreases the deleterious effect on asthma and chronic obstructive pulmonary disease. This is actually the study, an illustration that were researched, and these are the findings. And regarding pulmonary viral infection, vitamins and flavonoids are the main dietary components with antiviral actions. Individuals who has COPD, we advise them to take foods that are rich in minerals and vitamins. Those are antioxidants and anti-inflammatory nutrients, which will cause effect on the inflammation of the patient. Let's now see on nutrition-related consideration for respiratory disease. Aspiration. One is aspiration. Aspiration is a major cause of and aggravator for respiratory infection, particularly in pneumonia. And aspiration is the flowback of the intestinal contents, which will either enter into the trachea and cause pneumonia. Factors that increases the risk of aspiration. Number one is high residues, gastroparesis or impaired gastric motility, difficulty in swallowing or chewing. That's why we are saying you need to assess your patient well and know Which are the safest ways to feed the patient? Is it through enteral feeding? That's via NGT tube or other modes? Or is it that the patient needs to have parenteral feeding? That's intravenous. Then the strategies to prevent aspiration. One, you need to elevate the bed of the patient 30 to 45 degrees Celsius before feeding. And also you need to control secretion. Risk factors for aspiration. We have neuromuscular diseases or structural abnormalities of the aerodigestive tract, endotracheal intubation, we have vomiting. The highest percentage is vomiting, persistent high gastric residue volume. We have severe poisoning. Some of these like gastric high gastric residue volume comes as a result of when a patient is overfed, giving high volumes to the patient, and that is what will make the patient to have aspiration. Other additional factors, that is presence of nasoenteric tubes, non-continuous or intermittent feeding. Non-continuous or intermittent feeding. This is actually feeding a patient for staying for a longer times before feeding. You are not adhering to the schedules, plans that the patient is on. We have abdominal stroke thoracic surgery or trauma, delayed gastric emptying, also poor oral care. Age is also another factor. Inadequate nursing staff, large size or diameter of the tube, malpositioned tube, feeding tube, and also transport. This one risk factors is being adapted we adapted from the Markcliffe et al. Page 17. Refeeding syndrome. In simple terms, refeeding syndrome refers to the drastic drop in plasma electrolytes following the reintroduction of adequate nutrition to a severely malnourished patient. So when you introduce large volume of food to a patient who has not fed like for more than 2 weeks, you'll experience plasma electrolyte shifts, and that is refeeding syndrome. Most pulmonary patients are malnourished some degree as their disease progresses and can occur in the first week of feeding adequate nutrition to those who have been significantly malnourished for a long time. And it is characterized by the serum potassium, magnesium, phosphorus, which are low beyond the cutoff normal level. And these can cause heart failures or respiratory failure. And therefore, we need to avoid reintroduction of large volume of food for a patient who is malnourished and who has stayed for a longer time without feeding. And some studies says that the guideline says for a patient who has stayed for quite some time before feeding, you need to do 50% of the feed within 2 days. Then you go add 25%. No, you start with 25%, then you go to 50, and then 75 and 50. Within a span of 2 weeks, you would have attained 100%. But when you introduce the large volume of food that is supposed to be taken within, that is required by that patient. For example, if a patient requires 2,300 kilocalories in 24 hours, and you introduce the same amount, most likely that the patient will have a shift in potassium, magnesium, and phosphorus to come low below the requirement. the normal level. And therefore, we need to avoid that refeeding syndrome. How can we assess refeeding syndrome? We have initial risk determinants for refeeding syndrome. We have minor risks, A, major risk in section B, and very risk in section C. And these are individuals who are minor risks. The patient who is greater than 18.5 kilograms per meter square in the BMI scale, and the patient who has not lost 10% weight within in a span of 3 to 6 months, and the patient who has not experienced an intentional weight loss within 5 days, and then the history of alcoholic, those who have no history of alcoholic or drug abuse. Those who are at major risk of refeeding syndrome is those who have BMI below 6 kilograms per meter square, those who have lost weight more than 15% in a span of 3 to 6 months. Those are individuals who are at major risk of refeeding syndrome. Those who have very little or no nutritional intake within a span of greater than 10 days. Those who have not taken nutrients in a span of more than 10 days, and those patients who have the serum levels of potassium, phosphate, and magnesium are low below the normal range. And those who are at very high risk of refeeding syndrome are those who have the BMI of below 14 kilograms per meter square within the BMI scale, those who have experienced greater than 20% of the weight loss, and those who have starved for more than 15 days. This could be due to various factors, ranging from individual, family, and also the health of an individual. And this is by Reba, 2019. And also the risks, we put them in a band, the yellow band as an indicator of those who are minor risk, the amber for those who are at high risk, and the red for those who are very, very, very high risks. So that for our own feasibility and also for our own judgment and action plan. This is actually a further detailed illustration by Raba, but the other one was actually a summary of this, the nutritional, the risk factors. And to come up with the risk factors, you need to have a screening, nutrition screening tool. And this screening for nutrition risks and risks of refeeding syndrome. So those who have no risks of refeeding syndrome, low risk of refeeding syndrome, high risk of refeeding syndrome, very high risk of refeeding syndrome, then you need to make sure that you correct and make an intervention so that it favors the patient and it will not put the patient in a state that will cause panic. Preventive measures, we check on the electrolytes, thiamine, substitution, thiamine supplementation within at least 30 minutes before refeeding. We check on the nutrition, so we provide nutrition support, fluid maintenance. We do administration of micronutrients. Then we provide nutrition support, fluid maintenance, administration of micronutrients. Also nutrition support, fluid maintenance, and also administration of micronutrient. These are both on those who are at low risks, high risks, and very high risks, so that we make sure that we correct the fluid balances, we correct the micronutrients, for this particular patient. And all these needs, we need to follow the standards of care so that we may achieve and prevent feeding syndrome. So for those who have low risks, high risk, very high risk, we have interventions, nutrition interventions that we put on place for the first 6 days, depending on the weight of the patient, depending also on the status of the patient as per the classification. And these are nutritional requirements that you need to give in terms of calories for the patient from day 1 to day 10. Also, fluid maintenance, you need to check on the respective quantities, requirements per kg body weight between the same entry point of the patient. And for those who are at low risk of feeding syndrome, the nutritional support at that particular day, you need to give 15, between 1 and 2 days, you need to give 15 to 25 kilocalories per kg body weight per day. Then that is for day 1 and day 2 and day 3. In the day 4, you give 30 kilocalories per kg body weight per day. And in the 5th day, you go for full requirements. And then fluid maintenance, you start at 30 to 35 ml per kg body weight, and you don't restrict sodium. Day 1 to 3, you tend to give 200 to 300 milligrams of thiamine, and day 1 and 10, you give multivitamin. For those who are at high risk of feeding syndrome, during the first day of entry, between the first 3 days, you give 10 to 15 kilocalories per kg body weight per day. Between the 4th and the 5th day, you give 15 to 25 kilocalories per kg body weight per day. And day 6, you give 25 to 30 kilocalories per day. That's actually the full requirement. And by day 7, you give the full requirement. Fluids management, between the first 3 days, you give 25 to 30 ml per kg body weight per day. And from day 4, you give 30 to 35 ml kg per day. Sodium restriction, between day 1 and day 2, you restrict between 1 millimole per kg body weight per day. And day 3 to day 4, you give a thiamine of 200 to 300 milligrams per kg body weight. 200 to 300 milligrams, that is per day. Then as you continue with multivitamin. All these patients, low risk, high risk, very high risks, we give thiamine, we give and multivitamin continuously as per the prescription. Nutrients drug interaction. Dry mouth, throat, nose, vomiting, diarrhea and tremors. Diarrhea, hand tremors, headache, dizziness can be due to a sort of bronchodilators. These are drugs that are given to dilate the bronchus. Example is albuterol. We have also antibiotic protect against infections. We have anticholinergics, that is antihistamine. Example is Benadryl, suppresses the allergic response to stimulus. This is the environmental stimulus. It can be either a dust, smoke, perfume, or any other thing that can cause dilation. We have also anti-inflammatory agents, that is corticosteroids, that is example is prednisone, which suppresses airway inflammation. An example and how corticosteroids works, it creates increased appetite and insomnia, weight gain, that's a result of increased appetite, and also decreased activity due to insomnia. We have also insulin resistance, hyperglycemia, sodium retention, fluid retention, and which will cause edema. And all this creates negative calcium balance, leading to risk of osteoporosis. And that's why when a patient is put on corticosteroids, there is possible weight gain, insulin resistance, some goes to diabetes, hyperglycemia, that's increased blood glucose. We have also sodium restriction, which will cause fluid retention and which will be evident by edema. Therefore, in the summary on the requirements for patients who have chronic these diseases, we give the energy requirements and protein intake should be increased for crucial function and also to improve the quality of life, functional outcomes, and muscle mass in these patients with lung diseases. So actually the aim is actually to promote, to prevent muscle loss and also to improve the functions of the muscles, pulmonary functions, and also to improve the quality of life so that the patient may not lose weight. Another one is it is important to avoid excessive carbohydrates intake, which will prevent carbon dioxide production, which will lead to respiratory burden. And therefore, the levels or the amounts of carbohydrates should not be more than what we have prescribed in the first table, that we need to give more of fat so that we can prevent carbon dioxide production. Vitamin C, A, C, D, and E, also selenium and zinc are important strength in the bodies. They are all antioxidants that will defend damage of the tissues by oxidants, which can cause oxidative stress in the lung disease. Micronutrient assessment is very, very key, and supplementation where necessary is recommended. Diet rich is antioxidant, especially omega-3, fatty acids, and low in saturated fats, and processed foods. The Mediterranean diet are recommended to reduce inflammation and support lung health. Malnutrition management. Identifying and addressing malnutrition is critical as it is associated with poor outcomes, including lower quality of life and high mortality. And therefore, in patients who are overweight, we encourage them to lose weight by prescribing diet that is meant for not to increase the weight and should be higher than 25 kilocalories. Should be calculated by 25 kilocalories. Diet that is rich is antioxidant. These are actually the seafoods which are found in fish, fish is rich in omega-3 fatty acids, and it's very, very, very important. And therefore, we are saying those patients who requires antioxidant, you can prescribe them omega-3, or you advise them to take the seafoods. Thank you. These are the reference where I got the information about the management of patients with such patients when you come into contact. Thank you.
Thank you very much, Mr. Robert Kemboi, for that insightful presentation. Well, as you see from the slides, that was very quite informative information that we needed for this particular presentation. So for the ones who are having questions, please channel them through the Q&A tab that is available, so that now it may be able to address some of those questions that will be arising. Because as I'm looking at the Q&A, I cannot see any questions pertaining to the presentation. Perhaps there is one here from Gereso who is asking, what are the 3 take-homes for a patient with COPD as of whatever that has been presented? So perhaps it is more of a mind-boggling, or if I told you to ask the audience, what are the 3 take-home messages for patients with COPD? So Kemboi, perhaps would you want to take that one up, just in point form, in terms of when you're managing these patients who are having this COPD, what do they need to be cognizant of? I believe that is a concern from Ingereso.
One, it's important that you assess your patient. You carry out a thorough nutrition assessment of this patient, basing on you take the weight, anthropometric measurement, you take the biochemical data, nutrition forecast assessment, and also dietary, you take the diet history of that patient. Then you assess whether the one that was carry out nutrition assessment of the patient. Number 2, calculate the nutrient requirements as per that time of the patient based on the current nutrition the assessment that you have carried out. Then assess the patient whether it's a risk of refeeding syndrome or not. Then you assess the patient, whether the patient is either in ventilation or in either mechanically ventilated or not ventilated. Assess the patient whether it's sedated or not sedated. Then you do your calculation well. Then again, consider giving more of fat as compared to carbohydrates, so that we run away from excess carbon dioxide production. I think we have many take-home messages, but those are a few that I've picked. Maybe Agri, you can add some.
Well, just in addition of key interest, especially when it comes to COPD, you'll realize the most thing that we're trying to look at is in terms of alleviating the symptomatology on your patients. Because number one, perhaps when it comes now to nutrition aspect, you'd want to reduce the work of breathing in this particular patient? How would you do it? Because now it is based now on the last comment that you've made about addressing aspects to do with CO2 production, of which you'd want to look at in your macros or in your macronutrients. Which ones would give you a higher ratio of CO2 production? That's why during the presentation, if people are keen, there's the aspect whereby you are referring to the respiratory quotient, of which it's usually the volume of CO2 produced vis-a-vis the amount of oxygen that you're utilizing. And most often than not, you get like the starches usually are usually the very big countries in the production of CO2 on a patient, as they give you a respiratory quotient of 1. You should look at, if you to give proteins, perhaps they give you a respiratory quotient of approximately 0.8, and fats would give you approximately a respiratory quotient of around 0.7. So even in terms of when you're doing now your dietary therapy for this particular patient, in recognition of the fact that they're having COPD, you see that helps you in terms of being able to address their nutritional needs while still able to obtain the targeted clinical outcome in these particular individuals. That's what I can say in terms of the COPD patients. Thank you very much, Kimboy. Lucas Mugandi is saying, in patients at risk of refeeding syndrome, when initiating feed, which is the best feed to start with? Kitchen feeds vis-a-vis commercial feed preparations versus fortified kitchen preparation.
Thank you very much. Can go next. Kipoi, you have done a very wonderful issue, and it's really providing a lot of insights. Now, in regard to this question, from the whole presentation, what is coming out is that based on the risk assessment, it will matter more on the resources available. I don't think that if you are able to provide the caloric requirements that are suitable to the patient at that time, based on the feed that is within your setting, that is the most important thing. But of course, when you have commercial feeds or fortified kitchen preparation are more superior than just kitchen feeds, especially for patients on who require enteral nutrition. Yeah, because if patient is feeding orally and you are restricting caloric intake due to avoidance of refeeding syndrome, then perhaps fortification would be necessary for micronutrients, but not rather for caloric requirement because of the restriction that will be required for that particular time. Also, maybe what I've found very interesting in this presentation is the issue of lung gut axis. And actually, he talked about immunomodulator role of nutrients, and especially he highlighted on the issues of small chain fatty acids, the role they have in terms of reducing inflammation, because the role is to make patients to get into normalcy, especially in saturation. So it means even when you are deciding on which kitchen feeds to provide, it should be well constituted, so that it can also provide supportive role in management of these patients. Thank you.
Thank you, Alex.
Thank you very much for that response, Alex. Yeah, I think it's more or less to do with the therapeutic doses. You see, it all depends on what is at your disposal. such that if you're having the fortified kitchen feeds, then now you have to calculate now, would I have to dilute them so that now they don't end up giving you more than what is needed at that particular to create an imbalance on the patient. So I don't think there's any one period to the other, because I guess that is the direction of that's the direction perhaps he was seeking to be clarified. We have Warenzo here with a comment. He's saying, thank you very much, Kemboi, for your presentation, which is quite informative. Here comes a question in terms of we are dealing with critically ill patients in ICU and HDU, or even in the ward level. So they want you to expound more on how do you deal with these patients when they reach the ICU or the HDU, of which I think it was discussed in the presentation. Perhaps you can just do a recap for the critical ill patients.
What is very, very important is actually individualizing the care. As much as these are the guidelines, we are providing a guidelines that is near the safe limits, but what informs the amount of nutrients that one is given is the assessment that an individual patient is done. Thank you.
Maybe in addition to this is that the presentation has provided a generic view in terms of what are the issues that pertains to patient with COPD as far as nutrition is concerned. And they cut across, whether you have ICU patient, you have HDU patient, or patient in general ward, because even sometimes the patient is in general ward, and actually all the elements that have been highlighted here comes in handy. We have patients who are oxygen dependent, and they are on non-invasive support, and you find that their nutrition provision actually resonate with what our friend here has
Recording in progress.
Bianchi, agree on your side.
Yes, I think as we're trying to sort out the issue, it's all dependent in terms of the patients that you're having. And I believe in as much as you're having them, it's a matter of evaluating. So you see, when it comes to that, if they are mechanically ventilated, then now you see you also have to consider other aspects in terms of what is the mode of feeding for these patients. For those ones who are not, perhaps who are in HDU, you'd perhaps also realize like the mode of feeding would be mostly through the enteral route or using nasogastric tube for feeding this particular patient. So it all boils down to how do I deliver these nutrients to these patients so that I'm able to support their recovery for them to go back to the wards as it is supposed to be, or perhaps even go home. Let me see if at all there's any other question. There is a comment from Isaac who is saying what is taking home. The take-home message for COPD, number one is about quit smoking. So if you smoke, quitting is the most important step. That's aspect in terms of avoiding the triggers, that is avoiding identifying and avoiding the environmental triggers such as that. Take the medications as prescribed, practice breathing techniques. There's the other aspect of staying active, engaging in regular physical activity, and then now attending pulmonary rehabilitation and monitoring now the symptoms. Those are comments from Isaac. I believe he was responding to the take-home messages that question that was being asked earlier on. I don't know, I cannot see any other question from my end. Perhaps I'll give the panelists just a minute or two, just to sum it up the presentation for today. And Kemboi, perhaps you can go first before we have a Mbogo.
I encourage everyone to make sure that before you attend to a patient, do the screening, do nutrition assessment, and do the needful so that we can prevent refeeding syndrome. I emphasize on refeeding syndrome because many patients are dying from this thing called refeeding syndrome, which is a silent killer. You may know not whether the patient has died because of complication or what, but it's because of the derangement or low potassium, phosphate, or magnesium levels, which will alter all the activities of the body. I think that is all I can say. I cannot repeat everything, but that is the little I have.
Okay, that is good enough. Well, perhaps Mbogo, you can go.
I don't want to add anything extra there. Perhaps what I would suggest is that this presentation is really informative, and I can see a lot that needs to be picked up from this presentation so that we can be able to improve nutrition care for these patients. And maybe we need to go an extra mile and have perhaps a national protocol or a nutrition guideline that is well formulated that captures all these issues that have been raised here.
And thank you for those insights, Mbogo and Kemboi. Well, I think from my end, I can say it is a very insightful presentation, of which, when it comes to lung disease, perhaps people might often overlook it and simply concentrate more on delivering oxygen to the patient. So it's not just a matter of delivering oxygen and being able to remove the CO2. It's also a matter of looking at the wholesomeness in terms of the care that is needed. So in terms of a multidisciplinary approach or collaboration is very, very key when it comes to patient management. So that now you can be able even to do, you see, even a physiotherapist will come in handy. So that can be able to recruit the lungs for these COPD patients or for patients who are having respiratory diseases, to be able to get them off the other support that is needed for their benefits or for very positive outcomes. And there being no any other comments or questions, I believe we can end our presentation from there and see you next time. Thank you very much for your attendance. Thank you very much for our presenters and the panelists. Have a great day. Thank you.
Thank you.
Thank you.
Okay, you share with me this presentation.